Heart failure and dysrhythmias. These are your objectives. Heart failure. So when it comes to heart failure, there is left-sided heart failure, right-sided heart failure, or total heart failure. Primary risk factors of heart failure. The first one is coronary artery disease. Coronary artery disease can be made up of a wide range of heart issues. It could be a long history with uncontrolled hypertension. It could be anybody that has already had any type of heart procedure, and it is anyone that has had any type of heart murmur in their history. Contributing factors that are modifiable are hypertension, diabetes, tobacco use, obesity, or high cholesterol. Those 5 things, while there can be a genetic component, diet, exercise, and medication regimen are able to help those 5 contributing factors. Don't worry about the patho right now. I want to focus on left-sided versus right-sided heart failure. So left-sided heart failure is all about the lungs. The patient is going to have a high heart rate, a high respiration rate. They're going to have a wet cough. They could have crackles. They could have wheezing. They're going to have something called exertional dyspnea and just regular old plain dyspnea. Okay? So anything left-sided heart failure comes from the lungs. This patient is going to be the patient that in bed they either have to have several pillows under their head or they're sleeping in a chair at night. Right-sided heart failure. Right-sided heart failure is edema you can see. So it's the descended jugular vein, it's edema in their legs, it's hand swelling. So all of a sudden the patient's complaining about they can't get their rings on and off. Maybe when the patient takes their socks off, they see the indent of the top of the socks in their ankle. Maybe they've been unable to get their shoes on and needed to buy bigger shoes. Right-side heart failure is aspects you can see. We'll get more to heart failure complications in a moment. So diagnostic studies. Diagnostic studies, we're going to be on the slide for a little bit here. History and physical, not just patient history, but we also want to know the family history too. Family history is going to be key. Did their parents have any type of heart issues? Aunts and uncles, older siblings, grandparents. Heart disease is incredibly genetic, and we see it mirrored from generation to generation. It is very common for the physician to order a chest x-ray. That was going to show us on a large heart, it's going to show us lungs, it can show us lung collapse, it can show us fluid in the lungs. So a chest x-ray is going to be certainly done. EKG, we'll get into those again a little bit. A BNP, lab study, BNP. BNP is for congestive heart failure, so heart failure. BNP is going to measure the severity of the patient's heart failure. Everybody does have a BNP count. Typical high BNP on the average adult with no heart issues is roughly 120. That's the normal high. I've had patients with BNPs in the 5,000–6,000s. Don't worry about hemodynamic assessment. So let's talk about echocardiogram and ejection fraction. Echocardiogram is a diagnostic test that measures the flow of the blood through the heart. It also measures something called an ejection fraction. An ejection fraction is the percentage of fluid pumped out of the heart with every beat. A normal adult ejection fraction is anywhere between 50 and 75%. It's very rare to have anything higher than that. And the lower you get with the percentage, the worse the heart failure. Less than 15% would constitute less than 15% would need immediate medical attention because it's not compatible with long-term life. Depending on what's going on with the patient, the physician may order a stress test. If you did not know, the cardiologist does need to be present for the stress test. They can't be on the other side of the hospital. They have to be present in the room. Sometimes when we have a patient in a stress test, we can actually send them into a cardiac event. So the last step with this would be a cardiac catheterization. So sometimes we have to send the patient to the cardiac catheterization lab, where we go either in the femoral artery or the brachial artery, and we go up to their heart where we can locate the block, possibly stent the block, or sometimes we would need to stop the cardiac catheterization if they were to need open heart surgery. So where we move on to treating heart failure, when it comes to cardiac catheterizations, during the cardiac catheterization itself, it's actually kind of boring. It's a really calm room. If you're an adrenaline junkie, cath lab's not going to be for you. But after the cardiac catheterization, that's when the nurse is going to get busy. So I want you to write down the 3 things that we look for the most in a patient that is recovering from a cardiac catheterization. The first thing that we look for is a potassium issue. The body might hold on to potassium or it could dump potassium, so we'll be doing electrolyte panels on this patient. The second thing we could see is they could have a cardiac dysrhythmia. It typically is not one that is life-threatening, but remember we went in and we messed with the heart a little bit, so the heart could be a little irritated with us. And the third thing that we're going to watch closely is bleeding from the puncture site. Now remember, cardiac catheterization either goes in the brachial artery or the femoral artery, and sometimes they like to bleed. So we're looking for something and watching for something called a hematoma. So the hematoma is a slow, steady bleed from the artery into the interstitial tissue of your skin cells, and it looks like a very reddened blister. That is considered internal bleeding, and high pressure and forceful pressure does need to be applied. So again, those 3 things, we're going to watch potassium levels, we're going to watch telemetry, and we're going to watch for any hematoma at the puncture site. Acute coronary syndrome. This could involve a heart attack, unstable angina. Oh, I'm sorry. Let me go. I forgot something on the previous slide on slide 11. Digoxin. You may have gone to or talked about digoxin in pharmacology. There is such thing as a digoxin, a digtoxicity, where there's too much dig in the body, and the patient's going to complain of halos in their eyes or possibly ringing in their ears. So that is a teaching aspect when it comes to dig, that they do need to seek medical attention. All right, let's keep moving on. So nursing assessment. Nursing assessment for cardiac issues. Now, if you've ever seen like a movie or a show where a patient comes in and they're clutching their chest and they're profusely sweating and they have pain radiating down their left arm, it's always the left arm. By the way, it could be either arm or both arms. That actually typically only happens in male patients. So, sorry, but in female patients, we get the more muted sign of heart issues and heart attacks. We get the GI upset, so you might be nauseous. We get jaw pain or jaw tenderness, and then we get severe fatigue. This is why more women die of heart disease than men, even though men have more diagnosis, is because our signs are muted. Diagnostic test for acute heart issues is called troponin. Troponin is going to measure acute heart attack The higher the number, the worse the heart attack. So BNP is for heart failure. Troponin is for heart attack. We've already talked about the stent procedure, the three things I listed. Don't worry about Mona, that's actually getting phased out. So we're just going to skip over those slides and we're going to go right to dysrhythmias. Electrocardiogram monitoring. This is just a fancy word of saying telemetry monitor. There's 12 leads. There's your lead placement. There will not be a question on the test that says where do you put the specific leads. It's just here if you're curious. Most of you already know where the leads go, okay? The different monitoring we can do, again, we're not going to get really into it. A telemetry monitor is a telemetry monitor, and an EKG is an EKG. So let's go get into the cardiac rhythms itself. This is an example of a 6-second interval strip. You can see the top are the R's. See the top there? It says P, which is a little bump, R, which shoots up, and S on the bottom, and then another medium bump, that's the T. We are more concerned about the R's. So in slide 23, count the R's. There are 8 R's, 8 of them. There's 8 peaks. So you take that number 8, you take the R's, and you multiply it by 10, and that is going to give you the rough estimate of this patient's heartbeat. So this is going to start your telemetry guided notes. So on the first page of the guided notes on the top, there's going to be artifact. A and B and the artifact on your worksheet, just different ways artifact looks. The nurse just needs to go look and probably change the leads. They're probably old or the patient has sweated them off, but this patient's not going to die. We just need to go change the leads. The next one we're going to talk about is normal sinus rhythm. Normal sinus rhythm is anything between 60 and 100. You can see that everything marches out together. There's a clear P, a clear R that shoots up, T on the bottom, S on the bottom, and then T on the little bump. So this particular patient's heartbeat is probably just over between 60 and 70. Nothing to do here. The NCLEX answer is continue to monitor as ordered. Sinus bradycardia. You can see here the amount of R's. There's only 4. So this patient's between probably 40 and 45, give or take. Now there is a difference between stable bradycardia and unstable bradycardia. So stable bradycardia is where the patient's heartbeat is so low, but their blood pressure, their orthostatic blood pressure is stable. The patient is not dizzy. The patient is not lightheaded. There is no signs of unstable. This is very, very common in athletes because they have a heightened vagotone. So like Olympians like Michael Phelps, NBA players, soccer players, they typically have a lower resting heartbeat because of their heightened, well-trained vagotone. So we're not concerned about them. They're stable. Let's talk about unstable sinus bradycardia. Unstable sinus bradycardia is where their blood pressure is dropping and they go hypotensive. They're dizzy, they're diaphoretic, they're passing out on you. Okay? There's a wide variety of reasons that this could happen. Sometimes it's a medication issue. They're put on a beta blocker and the beta blocker is just working too well. In that case, the beta blocker needs to be stopped or the dose needs to be cut down. But maybe they have sick sinus syndrome, which is a weakening of the heart, or they have hypothyroidism. They're dealing with that. Sometimes what's going to happen is the physician is going to have to put a pacemaker in. The pacemaker rhythm is not on your worksheet, but I wanted you to see what it looks like in case you saw it at clinical or your job. So this is kind of a really weird telemetry rhythm. You can see the spike, the little arrow of the pacemaker spike. That's the pacemaker telling the heart it's time to beat. Pacemakers now also have defibrillators put in. So if the patient were to go into rhythms like VFib or VTAC, the defibrillator could shock them at home. It's made of titanium for the most part, and it is TSA and metal detector safe now. Sinus tachycardia. Sinus tachycardia. So this would be anything where the pulse is over 100. Now there are 5 main reasons someone is in sinus tachycardia that we have to do something about. And this isn't the sinus tachycardia where you go work out and you're doing cardio workup and you want your heartbeat higher. Okay, this is they don't want their heartbeat higher. So maybe the patient's in acute pain. Well, how do we treat acute pain? We give them pain medication. Maybe they're hypovolemic, they're severely dehydrated. We need to give them IV fluids. Maybe they're beginning to have a heart attack, and that would be a code STEMI and get them to the cath lab. Heart failure, like we talked about earlier, heart failure, both left or right-sided. Typically, the treatment, the beginning treatment for heart failure is going to be a beta blocker and a diuretic. So a beta blocker to help the heart beat more efficiently and a diuretic to get that fluid off. And lastly, a fever, and we give medications like acetaminophen, antipyretics to fever patients. Here's all the answers for you. Next one, slide 33. Premature arterial contractions, better known as a PAC. A PAC is one that looks like the beat has just came a little too soon. This is not going to kill anybody, and it is quite common for individuals in more of a stressful job or stressful situations to have the PAC. It's the body's natural response to stress. You can also see it in individuals that take in a high amount of caffeine and or alcohol, and you see a lot of PACs. It will not kill the patient, but they typically can feel it. It feels like a flutter, or it feels like the heart skipped a beat. So we don't want to ignore it, but it's not going to kill the patient. Most of the time the conversation is, why are we at this stress level, drinking too much alcohol or drinking too much caffeine? What's going on? Atrial fibrillation. Atrial fibrillation. The most common abnormal heartbeat that we have in the country. This particular slide on slide 35, this patient's beating about 50 beats per minute, and this is a controlled AFib. It's where you have a nice QRS and then it's squiggly lines in between. So when you have somebody with atrial fibrillation, they are going to be on Coumadin probably for the rest of their life. Doesn't matter what type of AFib. There are other medications out there, but right now NCLEX is just focused on Coumadin, so that's where we're going to stay. Okay. So an individual on Coumadin is going to be at a higher risk for bleeding. So if they have dental procedures done or they have minor procedures done, even if they're just going to a pathologist or dermatologist, they do need to let the doctor know that they're on warfarin because it will have them bleed more. So we have to double check. And if they start bleeding, we just put pressure on there, okay? They also, a stable atrial fibrillation, they also will probably put on digoxin or a beta blocker, just like we talked with heart failure, just to help to keep the heart beating more efficiently and slower. Now, for uncontrolled AFib, this would be when a patient's heartbeat is in atrial fibrillation and over 100 beats per minute. Their blood pressure will start to go down. They will start to get diaphoretic, dizzy. They'll have orthostatic hypotension. So this is not a patient we'd want to get up. The very common medication we give to treat uncontrolled atrial fibrillation is an antidysrhythmic called amiodarone. It's called amiodarone. Amiodarone is an antidysrhythmic drug that is given in IV form. It is in PO. They do have it in PO, but when we're in uncontrolled AFib and the patient's suffering, we're going to hit them with IV boluses and IV drips to calm the heart down. So it's called amiodarone. Any cardiac drug that we're doing drip for a patient will never just be turned off. It will always be weaned down or titrate down or step down, whatever you want to talk about. You just don't turn it off. You turn it down, okay? And there is a possibility that the physician may shock this patient, which is called a DC cardioversion, but that would be between the doctor and the patient, okay? Premature ventricle contractions, better known as a PVC. PVCs are incredibly common. We all get them. It's really not going to cause an issue, only if it brings about 1,000 of its friends, because a PVC can turn into something called ventricular tachycardia, better known as VTAC. If you notice the rhythm on your slide here, slide 40, or the handout, they're basically really big, awkward triangles with no bottoms. This is VTAC. They can look different depending on if they're monophobic or polyphobic, but that doesn't matter, okay? There is a difference between stable VTAC and unstable VTAC. Stable VTAC, the patient is going to be awake, their blood pressure is going to be within normal parameters, and a lot of times I've had patients walk into the ER with stable VTAC. And the most common drug we give for stable VTAC is a medication called adenosine. Adenosine stops the heart from beating for 3 to 5 seconds, and the hope is that when the heart restarts, it's in sinus rhythm again. The worst thing that's going to happen is it doesn't work and they just go right back into VTAC. For unstable VTAC, that's when we're going to cardiovert the patient. So cardioversion for VTAC is a little different than every other shocking we're doing. Cardioversion is you put the pads on the patient, and on the monitor there is a little button, I should say on the code machine, there is a little button called sync, S-Y-N-C, sync. We hit that button when the patient's in VTAC, and that tells the machine that they need to assess for VTAC. And you know the machine has recognized the VTAC when on top of the triangles, so the VTAC triangles, on top of the triangles, there's going to be these little tiny triangle dots that show up. That is going to tell you and your team that the machine is ready and it understands the patient's in VTAC. Before you hit that shock button, we have to make sure that nobody is touching the patient, nobody's touching the bed, and the oxygen to the room has been turned off. It is possible to cause an implosion from cardioverting the patient with the oxygen flowing. You are introducing an electric source into a high oxygenated room. Please make sure the oxygen has been turned off. All right, asystole. Asystole, the patient is pulseless. I don't care how many TV shows or movies you've seen where they're shocking asystole patients. We do not shock asystole patients. There's nothing to shock. So if your patient does not have a pulse, we do CPR. CPR, 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 CPR. No pulse, CPR. If you're curious, the causes of asystole are listed. You do not need to know them, but just if you're curious. And the last telirhythm is something called pulseless electrical activity. This is going to be treated identically to asystole. There is no pulse, pulseless, no pulse. CPR, 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 CPR. We do give epinephrine for this patient, and if we get any type of rhythm, they're going to give atropine to speed that rhythm up. But if the patient does not have a pulse, you do CPR. We do not shock someone that has no pulse. There's nothing to shock. This is just a picture of a defibrillation machine. You've probably all seen one at the hospital. They all look pretty similar. So last concept for this is peripheral artery disease, PAD, which is a narrowing of arteries in any aspect of the body, but we do see the results in the legs and the arms the most. So the most common signs that you see, their limbs will be cold, change in color, they're numb, they have a weak pulse, sores that won't heal because the body, the limbs, and the digits are not getting the nutrition and the oxygen needed to survive. Some complications, ulcers and skin necrosis can happen. I've unfortunately had to assist in removing limbs and digits because of this. So if the patient does ignore it, they can lose limbs and digits. Different diagnostic tests, and they're pretty much all ultrasounds, okay? Doppler ultrasound, duplex imaging, handheld Doppler, it's all Dopplers, okay? Just all different types of Dopplers. Modification, maintaining a low blood pressure, getting the sugar down if the patient's diabetic, getting cholesterol level down, and if they are a smoker, reducing smoking. The three most common treatments, the first one is a blood thinner, either high dose aspirin like 325 milligrams or a Plavix. That's the first one. The second one is going to be an ACE inhibitor. ACE inhibitors increase peripheral blood flow. And then the last thing, the third thing, is walking. Walking. So again, the most common treatments are an antiplatelet, an ACE inhibitor, and walking. Walking will do a patient with PAD worlds of good. And if a patient can't get up and walk for 30 minutes at a time, well, maybe they can walk 3 separate times during the day for 10 minutes, whether it be outside, on a treadmill, standing in place and walking, I don't care. All of it is going to help.